I also work for the University of Miami and have served as the chair of the exercise physiology program and the graduate applied physiology program in nutrition. And I focus my research at the university, and I focus my time at HealthSnap on telehealth and solutions, digital care solutions to optimize patient outcomes. It's really been exciting to see things that began really as a research program at the University of Miami scale out into an innovation that is helping thousands of patients through HealthSnap using evidence-based strategies and technology. It's been very exciting over the last, say, 6 or 7 years that we've been doing this. And let's go ahead and get started. So as I mentioned, today's discussion, and I'm really excited to talk about it because it's a super important discussion, is to talk about how remote monitoring of patients with hypertension using simple technology and a common sense method of implementation can greatly improve the assessment and management of this very common condition among patients here in the United States, and also provide not just better outcomes to the patients, but increase revenue for physicians as they see their patient outcomes improve. So first, a little bit of recap on the epidemiology of high blood pressure. We obviously know that it's common, but it really jumped up in 2017 when the American College of Cardiology and the American Heart Association changed the diagnosis guidelines from 140/90 to 130/80. And we saw hypertension being about 1/4 of Americans jump all the way up to about a half of Americans, 120 million Americans with hypertension right now. And sort of the scariest part about that is that 3 out of 4 of hypertensive patients in the United States are uncontrolled, which is somewhat of a paradox considering all the treatments that we have available. And now, as I'm going to speak about the technology we have available to better manage the condition. So the fact that 3 out of 4 hypertensive patients have uncontrolled hypertension is obviously a big concern, especially when you consider that hypertension contributes to about 500,000 deaths in the United States, a similar mortality as what cancer causes per year. And it's also very expensive, $130 billion annually spent for managing patients with hypertension. So we obviously have to do something about it. And it starts with an adequate and accurate, reliable diagnosis of high blood pressure. You know, I learned as a grad student, this is sort of a humorous anecdote real quick, I'm gonna share with you. I learned as a grad student how easily blood pressure measurements can be altered by the physiological state of someone, especially sympathetic responses, being anxious. When I managed a wellness center, and I had all my personal trainers that I managed conduct wellness assessments in the office, which included a measurement of blood pressure. And I had one personal trainer that a lot of the clients thought was very attractive. And a lot of the male clients, middle-aged or older, would almost every single time they had blood pressure taken by her, their blood pressure was elevated more than it should have been. So we ended up having other people at times have to take the blood pressure for those patients. So I got to see it firsthand. That's not white coat, that's sort of gym apparel hypertension. But either way, we know that white coat syndrome is an issue in the office where patients are obviously anxious in that environment, which can affect their blood pressure. In fact, you know, anxiety, feeling unwell, pain, all these are potential artifacts that can affect blood pressure. And usually patients in an office have at least one of those 3 things. There's also masked hypertension where for some reason, it's sort of the flip side of this, patients feel more comfortable in the presence of their care team or their provider, and they may actually present with controlled blood pressure in the office where ambulatory and outside of the office, their blood pressure is actually elevated. So diagnosis can be tricky, especially considering the confounding variables. And you know, there's a study that came out in 2014 that really categorized different elements of white coat and sort of some of these confounding variables of assessing hypertension. And obviously there's white coat, patients that have normal blood pressure at home, but actually present in the office with hypertension. Usually a younger person with isolated systolic hypertension, it's a good indication that it's probably white coat or there's a higher risk of it being white coat. There's also white coat uncontrolled hypertension, which is where patients who have high blood pressure and are being treated for high blood pressure, they're actually controlled at home. The the treatment is working well in terms of managing their condition. But when they're in the office, the anxiety of being in the office elevates their blood pressure, and it leads the physician to thinking that they're actually uncontrolled when they're actually controlled. The 180 degree sort of opposite of that is the MUCH condition, masked uncontrolled hypertension, where patients that have high blood pressure at home, they actually have their blood pressure pretty well controlled. I'm sorry, at home, their blood pressure is actually elevated, excuse me. But then in the office, they feel comfortable. And for whatever reason, their blood pressure is actually appearing to be controlled in the office. So exactly the opposite of white coat. In the office, they're presenting with controlled blood pressure measurements. And then at home in ambulatory conditions, they're actually hypertensive. So all of this really provides evidence to really focus more on home-based measurements of blood pressure and more regular, more frequent, consistent measures of blood pressure. So the guidelines have called for home-based measurements, out of office measurements to confirm and manage hypertension. And as I said just a moment ago, there's some indications that can help give you some insight as to patients that might be susceptible to like white coat. So if you have a patient under the age of 60 with that isolated systolic hypertension, we know that's more common among the elderly. Those patients have about a 400% increased prevalence of white coat syndrome. So to confirm that they have hypertension, if they're presenting in the office with isolated systolic hypertension, out of office measurements have been recommended since about 2012. And very similar to that, among patients that are hypertensive, they are much more likely, if they're under 60 with isolated systolic hypertension, to have white coat uncontrolled. So to confirm whether or not their blood pressure is being controlled outside of the office, once again, these patients, if presenting with isolated systolic hypertension, they're about 300% more likely to have that white coat uncontrolled, and they'd be better diagnosed from an ambulatory measure from home. So these guidelines in 2018 in the Journal of American College of Cardiology take out of office measurements. Let's confirm and manage that high blood pressure out of the office. And around 2018, around the same time, remote patient monitoring codes were presented by CMS for providers to start implementing this with their patients. Now, a lot of the physicians that we talk to, a lot of the practices that we interact with at HealthSnap, they still are not quite sure what remote physiological monitoring or remote patient monitoring is all about. So this is a high-level overview of how this goes for if you're going to remotely monitor a patient with hypertension, which we believe obviously you should. It's going to give you more accuracy. It's going to provide and lead to better outcomes for the patient. But this is a simple overview. You have a device that a patient is given at home. Medicare patients have no copays. We provide devices for free to the patient. They use that simple device. The data is shared to a HIPAA compliant, in our case, a high trust certified portal that the physicians can use to monitor the patients at a distance. They can be home-based monitoring of the patient, and they can be alerted to any changes that would need or necessitate changes in the way in which care is delivered. So from an RPM billing standpoint, not only is it providing, as I said, a service to the patients and increasing accessibility to the patients, but it's also driving revenue for practices. So just for setting up the patient on a device, and the pre-configured seller devices are so easy, the patient literally just pushes on and uses the device, and the data is going to be transmitted cellularly as if the device was a cell phone right to the portal. But setting up that device and getting that patient enrolled is a $21 reimbursement, around $20 reimbursement just for that one-time setup. And then monthly for the patient using the device, 16 days over a 30-day period, transmitting that data is about a $60 per patient per month reimbursement. And then for 20 minutes of engaging with that patient, talking to them about their data, talking to them about their other factors related to the data that's being transmitted, the consistency of it, the peaks and valleys and the measures as we look at it over time, that communication with the patient about the physiological data being monitored is going to reimburse it around another $60 per patient per month. And then every 20 minutes thereafter, another about $40 per patient per month. So you're looking at around a $200 per patient per month reimbursement that's possible if you're monitoring a patient and spending about an hour a month having clinical staff monitoring them, discussing the data with them, reaching out to them when there are alerts, either ups or downs in their data trends, et cetera. So one of the things that we use in our full service model to help, especially practices that have limited bandwidth, to add this seamlessly. We provide clinical staff that we call care navigators to work with these patients, help them get set up on the device, and talk to them, be the disseminator of information between the ordering provider and the patient. So what we see is that these care navigators that we're using at HealthSnap to communicate with the patient, we want them to be a guide on the side with the patient rather than a sage on the stage. That's the expression we like to use because we're kind of working along with them towards better care and treatment and management of their condition on a regular basis. We use monthly consults, and we're not preaching to them about what they need to do in terms of lifestyle change or in terms of medication compliance. We're just working alongside them and helping them feel like they have better control over their condition. We want to instill that improved self-efficacy. And we actually tell our care navigators to be the master of their domain. We want them to use this acronym on the consult, where the basis of the consult, of course, is to talk to the patient about the data that's been transmitted over the last month, take a look at days in which it's been higher or lower. Really important for predictive analytics and really understanding and evaluating the data is the O, which is obtaining measurements in a consistent and reliable fashion. Are they taking the measurements at the same time of day? Are they taking the measurements medicated or unmedicated? Are they taking the moment to relax, focus on breathing, and get the measurement in a similar resting state every single time? And then the M, of course, is medication. Or how often are they being sure that they're taking their medication? What are they doing to assure medication compliance and remembering to take it? How are they doing to get refills? Do they have any questions about their medication? We have the A, which is the assessment of the program. How do they feel about this? Do they feel more connected to their provider? Do they feel an increased sense of security through this remote patient monitoring program? For the patients that have an appetite for it, because our care navigators, as being a guide on the side, they also have to be able to read the room. So we want our care navigators to integrate evidence-based lifestyle strategies to help patients with the management of their blood pressure as long as the patient is interested. And what's nice about that is if there are even subtle recommendations for those patients that are really inactive or really have really poor diets, those patients, subtle changes can make really significant improvements in their health. So we try to integrate some lifestyle strategies where we can in these consults and make sure we schedule the next appointment. And what we love is that we're seeing these improved patient outcomes. And we look at after the first month of our full service model, remotely monitoring patients with hypertension, we're seeing a medicinal decrease in blood pressure just from the monitoring. So we see about an 8 millimeter mercury drop in systolic, 5 millimeter mercury drop in diastolic. Among obese patients in that first month, we're averaging about a 5-pound reduction in body weight. 70% of the patients are showing improved overall health outcomes. Every patient participating in the program, 100% of them after that first month, that's when we evaluate them, are saying they have an improved sense of security and they feel more connected to their care team through the remote patient monitoring program. 84% have greater control over their health. We're seeing this significant increase in self-efficacy, especially because of that augmented feedback that remote monitoring of blood pressure does for them. If we tell them that physical activity helps with lowering blood pressure, especially with the post-exercise hypertensive response, unlike just telling them that in a lecture format, they actually have their blood pressure cuff at home. So if they go for a walk and they take their blood pressure right after, they see that post-exercise hypertensive response, and it really motivates them to say, wow, walking is like taking medication. I'm going to do that more often. I'm going to take one of those walking pills, if we think of it as medication, every day. So they feel like they have more control. They have that improved self-efficacy. Every single patient also says they understand their health better after the program. That's a 100% increase in health literacy, And 3/4 of the patients in the program do something to improve their lifestyle based on the care navigator's suggestions as they go over the data with the patient on a monthly basis. So again, patients that are sometimes we see that patients are cavalier about lifestyle change. They're not really interested in doing it, but if subtle little changes can make significant differences. And this gives us an opportunity that, again, in the office, if you're just having them come in every few months and you're looking at blood pressure in the office, which might be confounded by various artifacts, we're seeing consistent measures. And we also, since we're touching base with that patient, we have an opportunity to share with them some evidence-based recommendations. Like, for example, weight loss can be very powerful, of course, for helping control and lower blood pressure, especially if we improve insulin sensitivity. And in the case of a medically supervised fasting strategy, they see an average of about a 30-point drop in blood pressure. So weight loss is extremely effective. There are all kinds of functional foods that we teach the patients about that they can simply add to their diet, which can make a very big difference in lowering their blood pressure. Flaxseed is probably the most important, the most critical dietary functional food for lowering blood pressure. The lignans in flaxseed actually have an ACE inhibiting effect similar to a medication and have been shown to help control blood pressure even more than adding an aerobic exercise program. And speaking of exercise, when we talk to patients that we're monitoring about the benefits, we really focus on the acute benefits, as I mentioned, right after exercise, how they see their blood pressure get lower to about equivalent to two doses of drugs in terms of lowering blood pressure after the exercise session. And that can last up to about 24 hours after the workout, after the exercise. And sometimes when we bring up that in the call, we're mainly focusing on the data and the medication compliance, and we kind of fit some of these lifestyle strategies in there. We make sure the patient understands that the reason we're doing this is because it's centered around them. It's anything but a dial for dollars methodology that we're using in communicating with these patients when they're on a remote patient monitoring program. And the care navigators have to read the room, as I said, and figure out on this transtheoretical model of change here that you see at the bottom left, where does the patient fall? How motivated are they to add lifestyle changes that can help manage their blood pressure? And what's great about this is that, if you look at the bottom stair here, where you have someone that is really completely unaware of their dietary problems or their stress management issues or their lack of sleep, lack of physical activity, and all these things confounding the problem, those patients, the smallest recommendation can make dramatic improvements. Now, at the top of the stairs, you have like a vegan triathlete. They're probably unlikely to be a patient anyway, but those patients are not going to benefit as much from the recommendations. But the ones down here, which is where most of our patients fall, if we give them just subtle recommendations, it's really impressive. So we came up with the idea for what became HealthSnap early on, shortly after the turn of the century, when we saw the diabetes prevention program looking at cardiometabolic disease patients, and that lifestyle change was 40% more effective than metformin at reducing diabetes, preventing diabetes in these pre-diabetic patients. So you'd have to have 6.9 patients engaged in a lifestyle program versus 14 patients taking metformin to prevent one incidence of diabetes in this pre-diabetic population. Very obviously a landmark study. And that's really, we got our start looking at lifestyle. And then we moved into technology and we saw the significant benefits of remote patient monitoring. We've sort of blended them. There's also been meta-analyses looking at the benefits of exercise compared to drugs. We're using randomized controlled trials and finding that for the secondary prevention of stroke and heart disease and other chronic conditions, that exercise was not significantly different from the medications. Now, of course, we don't have patients go off their meds. We just want to use lifestyle in conjunction, in an integrated way, in a holistic way with the treatment. And that's what's great about remotely monitoring patients with hypertension. You can blend the opportunity to consult and discuss the data with the patient and lifestyle recommendations and medication compliance along with the remote monitoring, which oftentimes in a busy practice, you can't do with those in-office measurements. And here's an example of some of the educational material we provide to patients that are interested, right? So as I get down to the end here, because I want to leave time for some questions, I'll say that we were so early on to this because we were focused on lifestyle and we were already including, before remote patient monitoring billing codes came out, we were already including wearables and home devices and the ability to sort of assess patient health and integrate that with the data that a practice is looking at for the management of their patients. So we were able to see some of the obstacles early on at adding this type of technology. So one of the things that's obviously going to be an obstacle would be frontline workflow. If remote patient monitoring is really going to burden the frontline staff, it's really hard for some practices to implement. But that's why a full service model where the clinical staff, like at HealthSnap as an example, is provided to the practice, we circumvent that obstacle. And it really doesn't burden the staff of a practice much at all because it's being used in this full service model by our supported clinical staff. The other thing is that a lot of clinical staff are reluctant, and physicians, to embrace a new technology. Many of them are frustrated or have trouble with their EHRs. So the good thing about a full service model is that our clinical staff has the day-to-day interface with the technology. And then the portal is available to the provider so that he or she can monitor their patients and see the data trends over time, see the notes that are being taken, see what's happening in the consults. But the day-to-day interface with that technology is really being handled by the supporting staff that's provided in the full service model. Of course, another issue that you hear all the time is, well, my patients don't understand technology at all. My patients don't even have smartphones. Well, again, we've circumvented that by including pre-configured seller devices that I mentioned earlier. A patient literally takes the free device out of the box, presses start, and uses it. And the data is transmitted directly to our HITRUST certified HIPAA compliant portal and available to the ordering provider. So the patient really doesn't have to know any technology whatsoever to get this program up and running for monitoring blood pressure from home. And then the last thing you hear is, well, yeah, but getting patients engaged is difficult. What am I going to do to really get my patients to take their blood pressure on a regular basis or to participate in those consults? Well, we find that adding a family member or caregiver to the conversation has been really effective in increasing that engagement, as well as catering those guidelines to that trans-theoretical model of change. How motivated is the patient? What is their appetite for learning about their health in these consults? And if we cater those recommendations appropriately, we see patient engagement like through the roof, much better than we've ever seen. As I mentioned, I managed a wellness center before, and I knew that January 1st around New Year's, you have all the new gym memberships. But by February, you should change your gym into a bar because you're going to see a lot of them quit their gym membership if you want to keep your attention, right? So, but in this remote monitoring methodology, we're seeing significant engagement. We're seeing 75% of our remotely monitored hypertensive patients performing some lifestyle changes to improve their health, which is really remarkable. So, in summary, we are in this really rapid transition in healthcare that's analogous to, in the entertainment world, the days of renting videos at Blockbuster Video to then going to Netflix and streaming movies, right? That's sort of the transition that we see right now in healthcare. And look, the guidelines call for out-of-office measurements to better assess and manage hypertensive patients. We have the technology that is very simple to use and enables these out-of-office measures to be performed by patients that lack even a smartphone or lack technological knowledge. For busy practices, of course, with that limited bandwidth, not a problem. A full service model, when you include that to monitor your patients as a physician, you have a streamlined workflow, a streamlined method, that doesn't burden the workflow and can be done rather seamlessly, yet getting significant amounts of data on your patients and how they're doing and improve patient outcomes. When you combine that remote monitoring, as I mentioned, with the telehealth digital care, you get better data consistency, you build in predictive analytics, you see strategies that are evidence-based to help patients with their lifestyle and their medication compliance. So millions of patients can benefit from the increased access and the improved management of hypertension when including RPM for part of your practice. The majority of patients do see that improved self-efficacy, those improved outcomes, those lifestyle changes. Again, remember, Medicare patients have no copays. And when we talk about the CMS codes and those RPM codes and reimbursements that come from that, we see about a 98 to 99% first pass clean claims rate from payers on reimbursing on these codes. So it is an opportunity not just for giving patients better care, but also seeing increased revenue. So RPM, remote physiological monitoring of patients with chronic conditions should, especially for hypertension, it should be the new criterion for all patients who have hypertension because of the improvements that you can see and increased access and all the things that I mentioned here. So I'm really happy to see what questions we have. It's 11:25, went a little bit longer. But again, as I mentioned, I am a professor, so I tend to be pretty verbose. I profess for a living. And I see some questions that have come in. One is with COVID sort of tapering down in some areas, what would be the importance of still doing remote monitoring? Yeah, so that's a great question. I think, obviously COVID, it was something we would never wish ever happened. There's so many terrible things that happened during COVID to our quality of life, and especially the number of patients that were affected with COVID. It was a terrible thing. But if we try to look optimistically at what came out of COVID that was positive, this move towards remote and digital technologies for healthcare, for improving healthcare, was greatly accelerated through COVID. And what it allowed us to do is allow us to see what things are working well remotely and what things aren't working as well. And as I have 5 kids. So for me, I've taken advantage of telehealth visits because especially with a 2-year-old and a baby, I have basically a petri dish here at home and lots of colds and things on a regular basis. And when you do your first telehealth visit as a patient, you want to keep doing telehealth visits. You see that convenience, you see that improved accessibility. And a lot of patients feel the same. Once they start doing things like being remotely monitored from home, especially something easy like blood pressure, they really question as to why they have to go into the practice, many of them, because they see here, look, this is the benefit. Being at home, much more convenient. A lot of patients that probably would miss their appointment or reschedule their appointment are more likely to make those telehealth appointments. They're more likely to take measurements on a regular basis if they know that a care team is on the other side seeing it. So I think that what COVID has done is it showed us the importance of including this technology and how beneficial it is for improving outcomes. Because without COVID, I don't know that we'd necessarily be here yet. We wouldn't have figured out as much as we have in terms of digital care. Okay, the other other question is physiological variable that is not being monitored from home enough. Right. So, there are a lot of use cases for remote patient monitoring. There's also been remote therapeutic monitoring, which is going to increase the use cases, I believe, significantly down the road. But I'm surprised that for obesity, it isn't prescribed more often. We have 2/3 of Americans that are either overweight or obese, especially when we look at android obesity and cardiometabolic disease. We know that we have about 1 in 3 Americans predicted to develop diabetes in a lifetime, which is a leading cause of kidney failure, limb amputations, and blindness, and all those other problems. So obesity, obviously an important condition. And there are cellular scales that can be ordered very easily, just like the blood pressure cuffs I described in this talk. And when you have that remote monitoring of daily routine measurements of body weight in a person who's obese, we can sort of eliminate that creeping obesity that occurs where we see patients adding 10 or 20 pounds a year because they become more aware of their body weight as it changes day to day. Just that regular measurement of body weight can be helpful. But then when you add that telehealth component where you're talking to the patient about their data and you're able to include those lifestyle strategies, you have a really good opportunity for managing obesity. So I'm surprised that there's not more medical necessity seen or prescription of RPM for obese patients. It's obviously a very important way to go, and it could be a really significant improvement in these patients' health. Okay. So I got to 2 questions, which I feel kind of bad about. I wish I would have gotten to more, but it's 11:30. I was told to stick very closely to this timeline. Actually, I have about 30 seconds. I don't know if another question came in. So are we finding Medicare Advantage plans patient copay for RPM to be a challenge? Now, as long as the patient is educated on the benefits of the program on the front end, as I mentioned, we see the vast majority of the patients are very excited about this because they see this as for them, and that's what's important. Again, it's anything but a dial for dollars. This is an opportunity for them to go to the office less frequently, to make their care team more accessible to them. When patients see those benefits, you have a few that are decline and might be skeptical of being monitored from home. But the majority of them, when they see that it's centered around them and it's making life easier for them, especially as you get, my 20-year-old stepdaughter, she orders groceries online, and Publix is literally 20 steps. Our grocery store here in Florida is right across the street from her, but she still orders online because it's so convenient. Can you imagine being a patient with heart failure, how arduous it is, of course, to make those regular office visits? Giving them an opportunity to get more of their care managed from home obviously eliminates that burden, and they become very excited about it. And with the continuity of care of having a regular care navigator working with them, they really feel like this is an improvement in what they're seeing day to day and in their healthcare. So we see the vast majority of them loving it and wanting to do it, despite small copays. Okay, well, thanks a lot for being here. I hope that you found this to be enlightening, maybe some new information.